I will talk today from the clinical and research user's perspective, from a person who used intracranial recordings and both for research and for clinic, and what I found really useful and helpful. And I want to start with my PhD work that I was doing. It was done at the University of Helsinki Central Hospital, MEG lab, biomag lab, and I was studying the effect of drugs on cognition, which was very interesting. These were drug challenge studies with the mismatch negativity response. And I used combination of both EEG, as you can see, this is me doing my PhD, and we were combining this together with the magnetoencephalography. So you see the same participant sits now already with the cap in MEG room. So this is the study that we were doing. And mismatch negativity, it is a response that reflects our involuntary change detection mechanism, which means that we can detect any changes in the environment, and we can test how our brain detects this change. And it is really very broadly used, not only in research, but now it is proposed as a biomarker, for example, for schizophrenia. There is research that is done in fetuses. We can provide sounds to the fetus and detect mismatch negativity response. There is even a whole MEG apparatus device that allows to do that. And it is used for detecting the state of consciousness for the disorders of consciousness, or helping to evaluate it. And you can look more if you want. It was day 9 actually of the BCI Spring School, and even in animals. So I think that's a fascinating research, day 5 of the BCI Spring School, if you want to look. So it's really something that is very, very broadly used. And of course, when a response like this is broadly used, we want to know where does it originate, where it is coming from, what are the origins of this response. And here we were facing a problem for a long time, because there was a debate of really where is this response originating. And we were trying to do it with this combination of EEG and MEG, so not only us, people in many other laboratories. And we know that there is a certain problem when we're trying to determine the origins of a certain response by using information that we collected from the surface of the brain. Yes, so tracing the origin of the brain's electrical response activity from scalp sensor readings. And we also refer to it as inverse problem. We need to perform inverse computations, which can provide us with definitely an infinite number of various solutions. And this is especially apparent if we are using EEG, less apparent if we are using MEG, but with EEG we have signal distortion, brain complexity and tissue interference complicates signal source tracing, and we need advanced techniques to do that. So basically, if you will see a shadow, we can try determine what is the source of that shadow, but basically this can be anything. We can fold our hands in many possible ways, yes, and at different distances to produce the same shadow. So that's the problem. And one of the main solutions to that problem was really research with depth electrodes with the intracranial recordings, which you can see here, which can be done when patients are undergoing epilepsy or brain tumor surgery. Mostly it's, of course, epilepsy surgery because they stay longer during the pre-surgical evaluation. So here you can see strips, here you can see depth electrodes, and very often also we can do the combination of both. And in these cases, of course, we have even more possibilities to explore the origins of the generations of certain responses, including mismatch negativity. So for comparison here, you can see one of the first studies that were trying to determine the origin of mismatch negativity response. So here you can see this by Temurina, and here is the mismatch negativity localization with the EEG source current distribution. So you see the area is really, really broad. We cannot pinpoint the sources really well. Here is a little better job that is done with MEG, and we know that, yes, it's more advantageous in certain ways than EEG. And here we can see the source localization of mismatch negativity. However, the debate still persisted because there was some indication that there should be also prefrontal areas that are generating mismatch negativity, and nobody could solve that. So this study by Rosberg in 2005, it very clearly pinpointed the sources of mismatch negativity that none of the previous non-invasive methodologies were able to pinpoint. And you can see here very clearly localized mismatch negativity responses. So you can compare the picture on the left, the picture on the right, and the precision with which intracranial recordings can provide us with the information that we really need. So with that, of course, we always very valued and still value tremendously the options that intracranial recordings provide us in terms of research and understanding of the mechanisms of various activities, various responses within the brain, their localization, and here you can see that, for example, electrocorticography. Of course, you know, this is a very very average interpretation. However, in general, we can say that EPOC provides us and with a better spatial resolution and with a better, of course, temporal resolution than other methodologies like fMRI can provide, and a better spatial resolution than EEG and MEG. Yes, so here where we will be sampling that information, the signal. And this is the reason why people want to conduct the studies, unique, unmatched insights. So the methods offer perspective that none other methods can provide. Global impact on science in general, understanding mechanisms and recognition, well regarded and acknowledged publications and work on the international level, of course, community esteem, gains publicity, prestigious publications that are really valued and used sometimes as a gold standard of research, and of course, increased funding opportunities. However, possibilities to do it were very limited in a way. And why is that? Because only few centers worldwide were doing this type of research. It's increasing. And I will explain what are the reasons for that. And there was a lack of common professional solutions. So there were no standardized systems in place. And usually people would assemble the systems from the components, gather them together. It was a work of PhD students or just scientists that work on a clinical team, and each of the team worldwide had their own solution that had, of course, many limitations. They were all custom built, developed in-house, and it also didn't allow for a really continuation of this type of research because it was difficult to teach each of new staff members how to work and with the system, and really it was off limits to many clinicians who need something that works really well and can be used on patient-by-patient basis. So we're prone to errors, difficulties in use, and steep learning curve, of course, required considerable time and effort to master. So the solutions came, one, I would say solution was first BCI 2000 in terms of software possibilities for this type of research, which we used. Here you can see our device, our system that we used at Florida Hospital for children and then adult program as well. It was BCI software, and we used at that time 8 g.tec amplifiers. So quite a cumbersome system. I worked with it all the time, and it really was difficult, to drag it to our epilepsy monitoring unit and bring it back and assemble and whatnot. So even here already with some software support, yes, the system was still fairly cumbersome. And then the new complete system was developed by g.tec, which, if you compare with that previous system that we had, of course, it looks so much better, so much smaller, very easy to really bring to the patient's bedside. You can bring it even intraoperatively to work with the patient. And also it has everything together already, not only software, but also all the hardware. Everything is connected so that we can work with the system. Plus, it has this unique research component which allows for montage. It allows for a stimulation if we want to combine it with the recording. So basically, a new solution, standardized solution, also FDA-approved devices that can be used easily by researchers, by scientists, by clinicians at the patient bedside and intraoperatively. So it's standardized, it's common uniform system that can be implemented industry-wide. Off-the-shelf reliability, so pre-built with robust features, minimizing the need for in-house development, user-friendly, error-resistant, intuitive to use with minimal bugs and issues, and easy to learn. So it's designed for quick mastery without extensive training. And it's available anywhere in the world. That's why the system becomes so popular. More and more centers in various countries around the globe, here in the United States, start to use it. And now this research that was done only in few select laboratories worldwide, it gets traction, and more people can have access to this unique possibility to learn about the human brain, the mechanisms that are behind many of our cognitive functions and very complex things that we were not able to study before. So that's the research perspective that I saw to develop and to change during my studies and already work at the clinic at the with patients. The second perspective is a clinical perspective. And this clinical perspective I gathered by working at Cincinnati Children's Hospital for 4 years, and then at Orlando, Florida Hospital, now Advent Health, for 11 years. And I work at the neurosurgery program, epilepsy center, and this is information about the epilepsy center at Advent Health, Orlando, level 4, so the highest designation center for both adult and epilepsy surgery, which has about 100 epilepsy surgery a year. So usually the team is really big. So here are just the main people participating. However, there are so much more. It's head of the surgery, epileptologist, neurologist, of course, neurosurgeon, neuropsychologist, neurophysiologist, MEG specialist, of course, neuroscientists, and many collaborators that also are involved. And for all of them, this system that can be used for clinical purposes, and of course it's still available for research, is very important that it would be easy to use, it would be standardized, but also would have a flexibility if it's necessary and required. And we focus on epilepsy, and we know that 20–30% of patients are resistant to the anti-epileptic drugs. So this who are our focus, this 20–30%. And we perform epilepsy surgeries. Still, our center performs the surgeries, and you can see our surgical suite, and Dr. Baumgartner here, our neurosurgeon, performing the operation. So now, who are our patients? Because that is our main focus, and dependent on who our patients are, we're selecting the best possible ways to help them. And these are patients, and in both places we had pediatric patients in Cincinnati Children's and Florida Hospital for Children. And these are patients often with debilitating seizures. And like Dr. Takioka mentioned, that these patients, they have many cognitive problems. So really the level of their cognitive development is usually not the same as their age. And this presents a big challenge because we need to have some approaches, some paradigms that we can use with children that are not always cooperative, that have often the level of development much lower that we can expect them. And here stems all the difficulty, what to choose, what type of approaches are best for these children. And we know that there are many factors that affecting cognition of these patients, and including anti-epileptic drugs and possible lesions, possible pathology of the brain, but we need to deal with all of that and choose appropriate methodologies to work with them. And if you look at the pre-surgical evaluation before the patient goes to a surgery, so it consists phase 1, phase 2, it's from our book chapter, and you can see how many procedures does this child needs to go through in order to get to the stage when the surgery is performed. So imagine this child with already the burden of seizures, the burden of developmental delay, difficulties, cognitive impairments, to go through all these procedures, even for adult, is quite difficult, not speaking already about the child. And importantly, that all the degree of the invasiveness of the procedures is increasing as we're going from phase 1 to phase 2 and further. So first, of course, the main focus is on localizing epileptiform discharges. What is the gold standard? And the gold standard is that invasive approach that I talked about when we started talking about research. This is implantation of grids, strips, or also depth electrodes, like I was explaining, and we can use patients on MRI to create a model of their brain, and we can visualize the information about the implanted grids here as well. So this is the procedure that allows us to determine what area of the brain needs to be removed, and we're doing this by recording the activity with these electrodes that we placed with electrocorticography in this case, and you can see how here we can really well localized, of course, not in all patients, but this is particular example that we can see fairly well where is that area of the brain that we need to take care of during the surgery. And the comparison of the same patients we see here with EEG. Yes, we can say, yeah, it's frontal, but we were not even able to say really well, is it left or right? Predominance, you see how it is broadly distributed through all the electrodes, so fairly diffused activity. So again, intracranial recordings provide us here with very unique perspective. However, after we perform, if everything would be so easy, yes, we would be able just to map certain areas of the brain that we just talked about, remove them, and we would have a happy patient, yes, with no problems. However, it's much more complicated, and again, you heard from Dr. Tanaka that it's not the full cure. That's number one. But number two is that, of course, every area of our brain is responsible for certain functions. And the main functions include, as we know, language, motor function, and when we're talking about language, is comprehension. It's also speech. So, for example, here you can see how the surgery impacted a patient. Here is the patient's preoperative MRI and the patient's post-operative MRI here, and you can see this dramatic change from pre and post. And this patient had functional hemispherectomy. So the parts of the hemisphere that generated seizures was removed. However, this part was corresponding to leg motor function. So in this case, the decision was made that we still can do the rehabilitation, that the patient can go through rehabilitation, and she is young enough for her brain to reorganize and for her to regain that function, but it took a considerable time, and you see here the rehabilitation, various rehabilitation procedures for her to start walking. So any intervention where there is an overlap between the area that we want to remove and the functional area, there is always a possibility for a patient to develop post-surgical deficit. So like you see here, here's the seizure onset zone, and here we have a motor function with the yellow. So there was a partial overlap, but because we determined where each of those areas are, we were able to do the surgery that didn't cause significant post-surgical deficits. So how to avoid it? So how to make sure that we don't cause those pre-surgical deficits? And we have, of course, non-invasive technologies like mittens, phallography, functional magnetic resonance imaging. These are also both Florida Hospital, current Advent Health. And sometimes it's really complicated for us to decide, okay, where are those functionally significant areas, yes, such as, for example, Broca's, Wernicke's, responsible for motor, visual function. And here you see one of those examples when it was really fairly complicated. So here are MEG spikes determined with MEG, so in black dots, and we were worried about the Wernicke's receptive language area. So if there is a possible overlap, and we were getting information that was not really very concordant. So, for example, here you can see with the MEG with orange dots. Yeah, so this is language. So, but how far it is from this MEG spikes? The same, we also get fMRI results, which are pointing us a little more posterior. Yes, again, so how far can we go with the resection, because there is even here MEG spike over here, if you can see. So when there is a lot of information that is really not very concordant, it's very important to have a gold standard that we always can rely on. And this gold standard is cortical stimulation mapping. And it has been a gold standard for many years already. And it has many advantages. So it provides accurate functional localization, which is also, sometimes under question, but among all methods, it is considered the most accurate at the moment. However, it has drawbacks. And again, imagine the child who needs to be stimulated, his brain needs to be stimulated also, which takes considerable amount of time because you need to stimulate each pair of electrodes. You may need to try it with the different intensities of the stimulation. You also need to check it twice, 3 times to make sure that that behavioral response that you receive, that you can see from the patient, that is really a behavioral response that is related to certain function. And it's not just something that the person spontaneously performed. Maybe the person just, his arm twitched, yes, not because it was stimulated, or maybe the person just forgot to continue reciting alphabet during the evaluation for Broca's area during stimulation in vicinity of the Broca's area. So there are many things that are associated with that. And plus, the biggest drawback that there are cases in which this stimulation produces seizures. Yes, so it can produce seizures, and we had quite a few cases. I wouldn't say many cases, but there were several cases when we were not able to perform cortical stimulation mapping at all because it was causing seizures every time we would try to work with the patients, even if the patients was already on anti-epileptic drug medication, so it was on medication already. And these cases need to be addressed in a certain way. So there is a need for some approaches that can cover those gaps, fill those gaps of, first of all, time, effort that is put into the mapping. Also, that would allow us to see the full picture of the activity on all the electrodes at the same time, and also that would not cause seizures, and that would be better tolerated by patients, especially by children. So, and this approach was proposed, it's referred to as high gamma mapping or real-time functional mapping, or CFM, like Dr. Tanaka was referring to it. And this is approach that we used in both places where I worked. So we would have a splitter box that would allow us to split the information from this grid, or now SEEG electrodes, into two streams, one for localization of the seizure at onset zone, so it would be a clinical arm, goes to the EMU monitoring room, and high gamma mapping, so separate mapping. And again, this is the system that we used. It was a research arm, and now it's available in this much better and convenient solution that I talked about when I was talking about research. But this research was a particular research because we were validating the high gamma approach. This way, it was the work of g.tec team that worked with us on this project. And also we were trying to find the best approaches of how to use this methodology, how it can complement or maybe even sometimes substitute the approaches that were already developed, like for example, cortical stimulation. And this approach was of this gamma mapping in real time was published by Dr. Sharp, Peter Brunner, and is known as Sigrid approach. This with what we start, and then this commercial solution CartiQ was developed that really streamlined everything. And just a reminder that we're looking at the high gamma frequency between 70, 110, and 130, 170 hertz, and we have a change usually in this high gamma, and usually increase of high gamma power with active task, when the person is actively engaged in certain task, which is differently from lower frequencies where there might be actually the decrease of that power. And the potential uses that we see is that this approach can be used both extraoperatively and intraoperatively. So we focused mostly on extraoperative approach. However, there are very nice studies, and Dr. Kamada and many other researchers that are showing this work intraoperatively. So first of all, how easy to use this paradigm, and again, we're talking about children. There are, first of all possible fMRI approaches that are used during the fMRI testing for this functional mapping can be used during high gamma mapping. These are approaches that can be created just for pediatric population, that are really children friendly, that can use certain test batteries for children for a specific cognitive developmental level, which is very important. So anything can be adopted. The usual approach is using similar design that is used, for example, for in fMRI, it's block design. We have a control condition and active condition. Here you can see a specific task, picture naming task that is developed for evaluating Broca's areas for localizing the speech, expressive language, and it can be 30 seconds altogether or 15 seconds each, or there can be longer version like here, 30 seconds. Control task and active task, and we can repeat it several times. Usually it's suggested 3 times to make sure that the results are concordant between each other. However, I would agree with Dr. Tanaka that when we prolong the tasks and when we repeat them many times, the effect subsides. So we don't see that big change in gamma. And there was a study that was showing it, I think it's g.tec, showed how gamma change, the power in gamma spectrum is decreasing with the repetition, even with the time. So this, of course, need to be considered, but in general, any paradigms. Here is an example of a paradigm for already Wernicke's stories that are really children-friendly. Christoph, please tell me if you hear, and then I will know that our listeners also hear.
A frog lived under a flower in the garden.
Yes.
One
yes.
day, a little boy picked a pretty flower. So the frog who licked this flower went inside.
Yeah, so really, this is Anna Byers, neuropsychologist at Cincinnati Children's, who created these paradigms, and they're usually very, very friendly. Again, can be used for any level of cognitive development. However, also these paradigms don't need to be presented all together, but actually they can be presented one after another in a block, like you see here, for example, tongue, motor mapping, listening to the stories, yes, so receptive language function, then looking at the Rubik's Cube, but actually it's for motor function, hand motor function evaluation, and so on and so forth. So we can create certain batteries. Again, it's very flexible. It depends on what we need, how our patient, how our child can perform, and we can do this, create those flexible combinations of different paradigms. What CRITIQ solution provides, it's already validated paradigms that went through validation, and we know that they really work. So for somatosensory, for motor, expressive language, auditory cortex, and receptive language areas, so all those paradigms have been validated already. And there are, of course, lots of flexibility, which is, again, especially important with the children, and we can add the paradigms that we need. And this is one of the examples of adding a paradigm, and this is Sharia Zedek Medical Center in Israel, where they mapped foot motor function, not even extraoperatively, but intraoperatively, and this is tumor resection surgery. So for tumor resections, there is a lot of interest in these approaches because it can be used intraoperatively. So can be used for foot and ankle control, knee control, even hip control, and we can look at the markers for all of those functions, and all of MRI tasks also can apply here, but we also can come up with our own solution, which we did a lot. For example, I did personally, dependent on the child. If you see that the child doesn't is not very receptive to one paradigm, or you don't see the results that you would expect to see, you can create very quickly another paradigm and test it. So this is about the block design, but because of the extensions that are available in CartiQ, we can also perform event-related mapping. So we also have event-related approach in fMRI. We know also event-related potentials. Yes, so we can use this event-related approach as well in constructing our paradigms, and we can see the dynamics of the response, which you can see here, that was performed with the already stereo EEG. So why do we need that? There are different purposes. We can see how the activity is spreading from one place to another, which is also very important for us to know. And we can track these dynamics here, for example, for motor function. And you can see how the areas are getting light up. And also very important, and I think this is what was mentioned by Dr. Kamada, there is new information that becomes available, that actually we can use gamma activity to find the best timing for cortical stimulation. For this, we need to see how this high gamma activity changes in time. So usually here we would look for the maximum of gamma activity, and the timing before that maximum peak would be one of the best for stimulation to elicit certain symptoms that we want to elicit, for example, during the naming task. And of course, like Dr. Tanaka was saying, that not always is easy to perform certain paradigms with children. Although there are many ways, yes, compared with even cortical stimulation or compared with fMRI, this approach is very flexible. You can make adjustments virtually very quickly and to work with the patients. However, still we're dealing with the blocks. So imagine you are saying to a child, you need now to stick your tongue, yes, and then you need to stop it. Very often it's really not effective. Or open and close your hand, yes, for 30 seconds, and then stop. Not really very effective. So you can see, especially with developmental delay, you can see children when they don't stop on time. So basically your resting period overlaps with the active period. There are things like this. Sometimes they just forget. They were doing it maybe for around 1. They forgot that they need to do it for the round 2. So there are many subtle moments. It's not doesn't happen a lot, but subtle moments that we need to be very vigilant about when we are working with children. So we really need to document it and make sure that they really are complying with this block design. So in many cases possible, but just if we look into the future, what can we do to maybe change a little bit the opportunities, especially for children? Yes, so for adults, it's not a problem, but for children, what can we do? And there is very interesting work that was going on. I think it's on hold, but I really wish this to continue, from Dr. Gilja group at University of San Francisco, I think, University of California, San Francisco. And this was done, PhD thesis by Paolo Gabriel. And you can see here a patient for evaluation for epilepsy surgery. His seizures being monitored. And here is the attempt to use current computer vision approaches to monitor the movement of these patients, the movement of this right hand, to map his motor area. So we will be looking at the correlation between the natural movement that occurs during normal patient's activity during the day, and then correlating this with the changes in gamma power in the motor cortex. So we would select a region, we would extract features, and we would track position of this arm to determine the localization of the motor function. So in this case, we can easily perform mapping virtually for any patients with any cognitive level of cognitive abilities of the development, and it would make mapping so much easier even without the need to come, yes, and purposely to do the mapping. Yes, so all this information is automatically gathered, accumulated, stored, and then updated to give us the result, let's say, by the end of the day, the end of several days when we already need this information. And although this was approach that was used only for motor function, mapping, but this can be done and for other modalities. Yes, it can be expressive language function because the patient definitely is talking and to the doctor, he's talking to medical personnel, to family members and whatnot. So again, having this in real time, in very natural environment, so very naturalistic approach in a way would definitely be beneficial, especially for children and children with developmental delays. So the question is, so now we know, yes, high gamma mapping, it can be used for language lateralization. This is our first study, Cincinnati Children's Hospital. This is the validation, then the work that we did together with g.tec. So we can localize fairly accurately language. Then this is a group from Japan, Dr. Agawa, showed that yes, it's validated of CARTIQ for intraoperative mapping. We also show that we can predict certain surgical outcomes based on the information that we gathered during this gamma mapping. It can provide additional value, predictive value, and not only predictive, but additive value. As already also Dr. Tanaka mentioned, that we can add have more information from all the electrodes at once, whereas we simply even don't have time and reason to test, sometimes a reason to test all the electrodes with the cortical stimulation. Yes, so that is one advantage that gamma mapping provides us with. And if we look at least at the data that we gathered, but it is similar to the new reports as well. However, it needs to be updated, I think, soon. And maybe we will do this update, I hope, in our new review article. There are definitely advantages of high gamma mapping: time and effort effective, safe, doesn't produce seizures, or, you know, at least most of the time. We never had seizures, but like Dr. Tanaka said, that there might be photosensitive seizures, and we present something on the screen that is flashing, you know, that would be a no-no. But I had several cases when people just said, you know, I don't feel comfortable with the flash. or they would say that my head starts hurting. So usually then you can transfer it to some other modalities. You can just show something in pictures, not necessarily on the screen. So you can change, and that is one strength of this high gamma mapping, that you are very flexible. It doesn't need very stringent settings. For example, in fMRI, the person needs to be very still. Again, advantage for children, especially who cannot be very still in fMRI. They can be more relaxed and have some movement flexibility during real-time functional mapping or gamma mapping. And it's well tolerated, much better tolerated by children than, let's say, cortical stimulation or laying still fMRI, and they get scared as well laying there alone. So, however, drawback, no accuracy still, if you look at the accuracy compared with the gold standard cortical stimulation, still not really there. It's much better for motor modality. So for motor mapping, it's almost there, but for language, it's not that great yet. Although better, we looked at the differences between cortical stimulation and high gamma mapping, and what we found that actually it's better, it has better predictive value for a receptive language function compared to expressive language function than cortical stimulation. Very interesting results. So maybe we can focus more on a receptive language function evaluation with the high gamma mapping, and more on expressive language function with the cortical stimulation. But this is just something that needs to be confirmed in further studies. So what to do? Yes, what are our options? So I'm wrapping up. We can think of, first of all, the use of high gamma mapping in those cases when other modalities really cannot help us. When there is a discordance between other modalities, high gamma mapping definitely can add information that is important. And this is, if you remember the first picture that I showed you with all those concurrent overlapping results, you would be able to see that actually high gamma mapping was showing at the area similar to MEG. So it was even closer to the spikes localized with MEG than any other modalities. Yeah, so in questionable cases like this is a great support. Secondly, in those cases when we cannot perform cortical stimulation because we are causing seizures. In those cases also, I was actually asked to come quickly on the weekend because the patient was rushed to surgery, but we still didn't have results from cortical stimulation because of the seizures. So in these cases, high gamma mapping was absolutely invaluable. Next, other approaches, we can combine it with cortical stimulation. We see that they actually can go hand in hand. In many cases, we can merge them. We can use cortical stimulation to high gamma mapping to navigate cortical stimulation. And also now we already know that we can determine optimal stimulation timing, which is very important. Actually, this work is also was shown in transcranial magnetic stimulation. It was for schizophrenia, but it was also shown that the activity, the neurophysiological activity that we record from the brain, it can help us to find the perfect stimulation timing. So here in cortical stimulation, in functional mapping for epilepsy surgery, this might be the case, and we really need to look into it. So this is one of the studies that we did with a group from computer vision, Dr. Bakhchi, and we merged gold standard cortical stimulation and real-time functional mapping or gamma mapping, and we classified positive and negative contacts for language based on ESM results. And then we were feeding this already upcoming ECOG activity from language task into this classifier to classify their contacts into language positive and language negative. So very interesting approach, which increased significantly our sensitivity, specificity, and overall accuracy. So, and again, of course, we can reduce the time of cortical stimulation by navigating. First, doing the high gamma mapping, yes, looking where we see the activation, especially because of the high sensitivity of the method, and then already to do cortical stimulation mapping at that particular place. So we're saving time, and also we're decreasing the chance of a patient to have seizures. This is the timing that I already mentioned, optimized timing for stimulation that we can do. And just to wrap up, why CARTIQ, why to use CARTIQ, so widespread availability, can be used at numerous centers globally, standardized professional solution, off-the-shelf reliability, user-friendly and error-resistant, easy to learn. Of course, the motivation, yes, unique, unmatched insights, and why to use it for neurosurgery, for enhanced patient comfort, for reduced medical risks such as seizures, efficient procedures, quick, streamlined, minimizing the burden on patients, increased accessibility, the use and safety of the procedure allow for more patients to undergo essential pre-surgical mapping and improve surgical outcomes. So that is the perspective that I gathered during my work in several institutions and learning about high gamma mapping. And yes, so that would be it. I invite everyone to listen to our NeuroCareers podcast. This week we have actually very interesting talk from Netherlands about SEG and decoding speech. So it's very relevant to what we were talking about, and this is Maxime Verwoerd, who also worked on CARTIQ, as I know, did a beautiful work at g.tec. So please tune in and listen. I hope you will find many insights in this podcast. And you can contact me at any time. Now I worked at g.tec for 5 months already. Very proud to be a g.tec employee. And you can, write any questions you have about functional mapping, CARTIQ. I'm happy to help. I'm happy to support you as much as I can with all the knowledge I gathered and still gathering. So at the moment. So thank you.
Thank you very much, Milena, for the nice talk. So you can see in the chat, people really liked it. Somebody's asking, what's the difference between EMG and MEG, so electromyogram and magnetoencephalogram?
Yes, so that's a good question. In EMG, we are looking at the activity of the muscles. Yes, muscle activity. MEG stands for magnetoencephalography. We are registering magnetic fields associated with the electrical activity. So if we have electrical activity, we all know about EEG. Yes, so that electrical activity always has a magnetic counterpart, which we also can register. And of course, these are tiny, teeny, tiny magnetic fields, and we need a special room to make sure that there is no interference. We need to use highly sensitive sensors that are kept in extremely low temperatures. So there are many considerations that we need to have when recording MEG, but it proved to be very helpful for non-invasive evaluation for epilepsy surgery, for functional mapping and for localization of epileptiform activity.
Thank you very much. I see also Masanori and Aishi here. Hello, good morning, Aishi. Welcome to come online and ask Milena.
Yes. Sorry, I have one quick question. A great talk, and also I guess we're friends with Hisako and also with Keely as well, so they know me well. But anyways, yeah.
Yes.
But anyways, about Korekyu, it's the default is 3 repeats. Have you seen the signal get weaker after the 3rd repeat? Sometimes I see the 1st and 2nd time they do it better, the signal's better, and it goes down on the 3rd time.
Yes, and this is what I talked about, that with the repetitions it yes. becomes weaker. So that gamma change is best during the 1st time. So it's the largest change that you can see, and then it subsides. Yes.
So should I make it 2 repeats instead of 1 and 3? Is that allowed?
Sure, you can.
Okay.
Yeah, thank you.
Basically, after 1 run, you got the information you need. And if it doesn't change in the 2nd one, you're done.
Oh, thank you. I see. That's so nice.
Milena,
nice.
Andre, or let's do David first because it's much shorter. This is the person who asked now 505 questions during Spring School. He's asking, what do you think is the future of ECOG research?
Yes, that's a good question, and we see that many centers are now turning towards stereo EEG, at least here in the United States. But I also heard, I don't know, I need really to investigate this question more, that there are centers in Europe who traditionally used SEG, that they are turning more to ECOG, because and one modality and another has many important information that can be used. There are cases when you need to use a combination of both, yes, dependent. So I don't think that ECOG possibility for ECOG research will get extinct very soon. Yes, so there are still possibilities to work with these patients, and we will have many possibilities still to do that. It's not going extinct forever. So we have many opportunities to do that. And actually, even for speech neuroprosthesis, yes, for example, the group by Eddie Chung, they are using for their speech neuroprosthesis, they are using ECOG electrodes. Yes, they are not going inside the brain, penetrating it and whatnot. So there is definitely a potential.
Very good. Andre is asking, when you work with children, very often, they're not doing what you want them they should do. So if you say, for example, stop, you can be sure they're still talking. So would it be better maybe to ask them to imitate a quiet animal, to be silent or something like that?
Yeah, such a good question. Absolutely. It's all about how you approach a patient. It's really, you need to be flexible. You need to be attentive to what is the best way for them to complete the task. Yes, maybe if it's opening a hand, maybe you can show the animal that is doing the same, and you say, okay, now this animal will be, your bear will be doing this, and you do this at the same time. You need to do it together with the bear because he might get sad or something like that. Yes, so you really need to work with the patient, especially with children, and find approaches that work just for them. Yeah, great question, great suggestion.
Masanori agrees, as I see. Hassan is asking, do you need a mobile MRI machine or a CT machine to place the ECOG grids on the cortex?
No, you don't need mobile system, so you do it. First, you do MRI, and it's used for many purposes. You do CT, then you add this information together, so no need for mobile.
And Jacob is asking, do you think the optical pumped magnometer sensors have the potential in epilepsy research?
I really hope that this development of optically pumped magnetometers will offer so many new possibilities, and cheaper devices, because you know that MEG in its current states with the squids that it's using, it needs this cryogenic environment and so on and so forth, and it's not available in many centers. So I think this new type of magnetometers, new type of devices, it will help to spread MEG to many other epilepsy centers. I really hope, but we still need to work on accuracy, on validation. And so there is a lot of work ahead of us, but definitely very promising, very promising.
Thank you very much, Milena. This was super nice. Look into the chat. They are saying, nice talk. Biggest fan of Dr. Milena. Superb. Lot of hearts. Make a screenshot. Show it to Ivan. Thank you very much.